Hi, I'm Dr. Afzal Sohaib. I'm a cardiologist from London, and I'm joined here at the ESC by Professor Greg Lip. Professor Lip, you're going to talk to us about the atrial fibrillation better care pathway, which you just presented at the ESC Congress.
Thank you. We had a hotline or late-breaking science presentation, and the aspect with regard to the ABC pathway, or rather the introduction or background to this, is that when we manage patients with atrial fibrillation, is to streamline the pathways for managing atrial fibrillation in a holistic or integrated manner. Many patients are elderly and have multiple comorbidities, but we focus a lot on the stroke prevention side, and perhaps quite rightly so. But stroke prevention is only one component with regard to managing atrial fibrillation. Ultimately, when we manage atrial fibrillation, we have to focus on symptoms, because this brings into the consideration or the discussion on rate control or rhythm control, but ultimately to be managing the patient's symptoms. Bear in mind the comorbidities and risk factors. We have to manage proactively the comorbidities and risk factors, cardiovascular risk factors attached to atrial fibrillation in a comprehensive manner. And the ABC background, the pathway background, was certainly what we do in the atrial fibrillation specialist clinic that I run.
Yep.
The concepts or the approach to managing patients with atrial fibrillation shouldn't be any different to what a non-cardiologist is doing in the rest of the hospital. And that shouldn't be any different to what a general practitioner is doing in the community. And also, when you talk to patients, you need something simple and easy to be able to describe to patients the principles or the main aspects of atrial fibrillation management. Hence the ABC pathway. A is avoid stroke. A is avoid stroke with anticoagulation. A for anticoagulation. B is better symptom management. And this is where you discuss the patient-centered and symptom-directed decisions on rate and rhythm control. The C is cardiovascular and comorbidity risk management. And that includes attention to things like blood pressure, heart failure, sleep apnea, diabetes, cardiac ischemia. There's the lifestyle aspects too. There's a lot of interesting data regard to obesity management, alcohol, stimulants with regard to atrial fibrillation precipitants, addressing that. We are addressing the patient as a whole, so we have to pay attention to the psychological comorbidity or morbidity associated with atrial fibrillation, and of course, taking into consideration patient values and preferences. So this is the ABC pathway that we develop in collaboration with our colleagues in primary care. The concept of integrated care is not necessarily novel, because there have been a number of small studies. For example, the Maastricht group have published nurse-led multidisciplinary integrated care, and that has shown better outcomes compared to usual care management for patients with atrial fibrillation. A meta-analysis by Gallagher published in Heart, looking at the small studies of integrated care, multidisciplinary care, also show a reduction in a reduction in mortality, a reduction in hospitalization. But coming up with the ABC pathway that we implemented, bridging primary and secondary care, there's no point coming up with a concept if you haven't actually tested that such an approach works. So we started a program of work, and today at the late-breaking science, we presented just the proof of concept, looking at a post-hoc analysis of a clinical trial cohort to see whether this pathway can actually work if you to model or you apply in the ABC pathway. So what we did was, to ensure some degree of uniformity, we only studied patients who were anticoagulated, and they were all on warfarin, because this was a post-hoc analysis of an old trial, the Affirm trial, that most of us will remember for rate and rhythm control.
So you've managed to keep hold of some of those patients with this.
That's right. So as a post-hoc analysis, it is in a sense, as I mentioned, a proof of concept study to show that the pathway works as part of a bigger program. So we define A, which is avoid stroke with anticoagulation.
Which they already have, because they're all on
but it's not just the anticoagulation with warfarin, we look at TTR. So we define optimize A as a TTR of 70% and above. For B, it's better symptom management. So we looked at patients' symptom status or symptomology, and if there are 2 or less symptoms reported, they were regarded as reasonably well controlled symptom-wise. If there are multiple symptomology, and quite a lot of patients had that, then they didn't fulfill the B criteria. For the C, we looked at a number of cardiovascular comorbidities. So blood pressure targets 140 under 85 as reasonably good blood pressure control. And for the rest of the comorbidities like previous ischemic heart disease or peripheral artery disease or heart failure, make sure they were appropriate secondary prevention therapies, for example, statins, ACE inhibitors, beta blockers, etc., etc. So we make sure that they were at least prescribed the optimized cardiovascular prevention strategies.
And for obesity, because that's very topical in the associated risk factors area.
Unfortunately, there wasn't any sort of sequential changes in that. But there's, as I said, this part of a work in progress now.
No, I'm sure. Yeah.
So, to our results. With regard to this post-hoc analysis, and we studied over 3,000 in this trial cohort, all with adjudicated outcomes.
Okay.
We saw a 65% reduction in mortality with the ABC compliant group compared to the non-ABC compliant group.
So were all patients offered or
those who complied, those who
pathway?
Those who fulfilled all the ABC criteria were called the ABC group.
Ah, I see. Okay.
Those who didn't fulfill,
I see. Okay.
were called the non-ABC group.
Okay.
So those who were compliant with the ABC criteria, i.e. the ABC group, that was associated with a 65% reduction in mortality compared to the non-ABC compliant group.
Big numbers.
Big effect size.
Yeah.
And
what were the absolute numbers of more risk reduction?
The absolute it's certainly just under 10%.
Okay, so it's pretty impressive.
So it's pretty impressive.
Yeah.
When you come to the hospitalizations, there was a significant reduction in hospitalizations and the composite outcome, which was the composite of stroke, bleeding, and cardiovascular mortality.
Yeah.
So these, we also did some exploratory analysis to see which components of the ABC were more important. Yeah. Obviously, fulfilling all the three criteria was the reference, reduction of all the composite outcome, mortality, and hospitalizations. If you fulfill particularly anticoagulant and the C criteria, which is cardiovascular risk, you also reduce mortality and also the composite outcome and the hospitalizations, and the others less so. And there seemed to be a graded relationship. If we fulfill all the criteria of the ABC pathway, compared to 2, compared to 1, compared to none, the Kaplan-Meier curve showed this nice separation with regard to how well you fulfill the different criteria. Yeah. So the late-breaking science session shows that if you apply a patient pathway based on the ABC pathway in an integrated or holistic manner, is associated with significantly better clinically relevant outcomes, including mortality, the composite, and also hospitalizations. There are limitations to this work. It's a post-hoc analysis of a trial cohort. It's a rather old trial, but nonetheless, it is outcomes that are adjudicated, and as a proof of concept, it does fulfill what we're doing. And this is part of a larger program of work, including a prospective outcome trial that we're undertaking.
Exactly. So can you tell us a little bit about that in terms of design?
I'll tell you next year when I come back.
Excellent. And I'm very interested in AF and ablating AF. Was there any indication of how risk factor management might affect AF burden? I know some of the group in Australia have looked at that.
Yeah, not in this particular analysis.
Okay.
But watch this space.
Watch this space now. I'm sure you will. Thank you very much, Professor Lip.
Pleasure.